Research chapters are about 50 pages long, and half of the time you can tell what is important. Before we get into the details, I always like to zoom out first to look at the big picture of the chapter. I use a concept map like these to break it down heavy chapters. Chapter 34 is all about all blood disorders. We have red blood cells, we have white blood cells, bleeding disorders, and the lymph nodes disorders. And I will categorize in 4. I'm going to start with red blood cells, which is all about anemia, and then the white blood cells disorders, then the bleeding disorders, and then lymph disorders. So we know the overview of the chapter. It's blood is a connective tissue composed of plasma, red blood cells, white blood cells, and platelets. We're going to find out in this chapter that offers a comprehensive exploration of blood disorders, beginning with this introduction to blend as a vital connective tissue composed of plasma, red blood cells, white blood cells, and platelets. This chapter systematically examines conditions affecting those components, classifying them in the key categories. I said red blood cells, disorders such as we see here an iron anemia, sickle cell anemia, we have vitamin B12, folic acid, aplastic, glucose 6, polycythemia. Then we go to the white blood cells disorder, focus on leukemias and neutropenia, which this chapter doesn't talk much about these disorders. For disorder including thrombocytopenia and with a lot of various of hemophilias. Then lastly, we have the lymph disorders like malignant lymphomas, Hodgkin and non-Hodgkin, and multiple myeloma. So understanding those diverse pathologies is essential for recognizing the signs and symptoms and underlying mechanism of hematological disease. So I'm gonna go in one by one, and I will explain a little bit of epidemiology, pathophysiology, clinical manifestation, diagnostic, medical management, complication, nursing assessment, nursing intervention, and evaluating care outcome. Before we start into the chapter, I want to tell you when we focus on the NCLEX, we do what mostly it's tested. So you're gonna see this as a little bit review. You see here domains, physical, adaptational, management of care, safety, clinical judgment, how you recognize, analyze the cues, reduction, risk, potential, safety and infection control. And so you can see, you can take a short screen quick. But like this, for instance, it's mostly in quizzes. And it's good to know as a nurse to how you explain to a patient about blood when you start this topic to talk about. So we start with red blood cells disorders. We have iron, vitamin B12, EC7, but somehow I found out in the chapter it's another disease. They talk very little, but it's not categorized. I should have done this, but I went by subtitles of the chapter when I made this chart concept map. So now we go one by one. We have iron deficiency anemia, and epidemiology is the most common anemia worldwide. High risk in menstruating women, pregnancy, and chronic blood loss. Is the most prevalent nutritional deficiency globally, common in socioeconomically disadvantaged group, infants, children, pregnant individuals, and adults more than 65, higher than 65, caused by inadequate dietary intake, chronic blood loss, poor absorption, or increased demands. Pathophysiology. Iron deficiency leads to impaired hemoglobin synthesis, reducing oxygen delivery to tissue. The body first depletes stored iron, then fails to meet erythropoietic demands. Anemia is a late-stage manifestation. So basically means inadequate iron, decreased hemoglobin synthesis, which results in low oxygen delivery. Clinical manifestation, how we gonna see? The main thing is fatigue, pallor, tachycardia, dyspnea, brittle nails, pica. So keep in mind the short of breath, glossitis, fissures at the mouth corners, spoon-shaped nails, koilonychnia, and pica. So these are the keywords that we have to look for this disease, this anemia, and how we diagnosed lab from blood, CBC. We're gonna see low hemoglobin, low hematocrit, low ferritin, low iron, and confirm with the full iron panel and possible additional labs like soluble transferrin receptor. Then medical management, oral supplements, vitamin C, for absorption, and dietary consulting. So keep in mind that this increased dietary iron, Heme or non-Heme sources, supplement with oral or parental iron, administer with vitamin C, avoid dietary at times of iron administration, monitor for GI side effects. And here you need to remember how we give, for instance, an injection. It's a Z, that's it, to form for injection. And keep in mind that iron stains. Complication, worsen fatigue, developmental delays in children, adverse pregnancy outcomes, impaired immune response. Iron overload may occur from pica or excessive transfusion. And keep in mind that heart failure connect cognitive delays in children. So incorrectly stated that iron is always contradicted in elderly. Not always true. Evaluate case by case. And for nursing, nursing management, monitor fatigue, tachycardia, pale mucosa, assess dietary habits, and GI bleeds. So first you need to assess, monitor for fatigue. So this the nurse will do, monitor for fatigue, pallor, tachypnea, LOC changes, blood loss, check for labs, especially for hemoglobin, ferritin, evaluate dietary history and assess for causes like GI loss or malabsorption. How a nurse will intervene: encourage iron and vitamin C rich diet, administer iron supplements, educate on side effects and avoidance of dietary. It's very important you give vitamin C and no milk. And assess for blood loss, monitor the labs. For evaluating care, the outcome, so what we like to see is to improve hemoglobin and ferritin in the labs, reduce symptoms like fatigue, pallor, short of breath, and normalize vitals. In children, monitor for continued cognitive issues if it's prolonged. So educate on iron-rich diet, administer iron with orange juice, recheck CBC in 4 to 5 weeks. And here we have nursing pearls. Given an empty stomach, stool black, green, use a straw with liquid iron because stains makes yellow. NCLEX, it's have a it's in severe deficiency, poor absorption. Vitamin B12, anemia. So it's most common in older adults, autoimmune gastritis, vegetarians without B12 intake, which affects about 15 to 25% in older adults, primarily due to gastric atrophy and reduced gastric acid. Also common in individuals with the GI disorders, chronic alcohol use, vegan and long-term users of acid-reducing medication. We have for pathophysiology, what really means is essential for red blood cells production and central nervous system function and DNA synthesis. It requires interesting factor for absorption and the ileum. In the ileum, deficiency causes impaired DNA synthesis and myelin degeneration. So we know it's lack of intrinsic factor, which decrease the B12 absorption, leads to impaired DNA synthesis and results in macrocytic anemia. For clinical manifestation, how we see into a patient, we see pallor again, fatigue again, short of breath again, tachycardia again, paresthesia, numbness. This is new for B12, confusion, glossitis, coordination difficulty, depression, viral changes, and in several cases dementia. So keep in mind this. This is a keyword to figure out what means. So glossitis, fatigue, memory loss, paresthesia. Vision changes are less common than neurological signs. How we diagnosed? Again, CBC. We'll see increase in MCV and decrease in serum B12, positive intrinsic factor antibody. So that is called the Schilling's test. We'll see that the hematocrit and hemoglobin also decrease. Then medical management, B12 replacement, oral for mild cases, an injection, intramuscular for severe or intrinsic factor deficiency. Encourage animal-based diet, avoid nitrous oxide in deficient patient. So for the injection, keep in mind that lifelong for Pernicious anemia, PO for dietary causes. Complication, it's irreversible neurologic damage if untreated. Pregnancy increases B12 needs. Radiation and acid reducing meds impair absorption. And so it's irreversible nerve damage if untreated. So what the nurse will do, first we assess mental status, gait, neuroscience. So for the neuro symptoms, is tickling, memory loss, mood swings, vital signs of course, and risk for falls. Monitor for intake and output, and vitamin 12. Intervention, administer B12 therapy, either it's oral or injection. Dietary education, monitor for neurodecline, assess for fall risk, evaluate pain from neuropathy, monitor nitrous oxide exposure. What else? Let's say the outcomes. Resolution of anemia with improved in CBC, hemoglobin, hematocrit, and B12 levels. Clinical improvement in fatigue, short of breath, and cognition. Some neuro symptoms might be permanent if not treated early. So these are the kind of keywords. Keep in mind, you need to educate on B12 injection. Monitor always for neural changes and fall prevention. Yeah. Okay. Folic acid deficiency anemia, often due to poor dietary intake. Chronic alcohol use, extreme diets. So the GI disorders or medication side effects. Common in older adult patients on dialysis and those with increased demands like pregnancy and infancy. So common also in alcoholism, poor diet, pregnancy, elderly. Pathophysiology, it's folic acid B9 is essential for DNA synthesis and red blood cell maturization. Absorbed in the duodenum intestine, deficiency leads to delayed erythrocytes maturization, decreased hemoglobin, and increase in homocysteines level. So, inadequate folate, decrease cell diffusion will lead to macrocytic anemia. So the clinical manifestation, again, we see fatigue, pallor, tachycardia, but neurological symptoms are not present. These distinguish it from B12. Might be paresthesia, numbness, confusion, desorientation. So this dizzy, confusion, desorientation, no neurological symptoms like paresthesia. I said earlier yes, but no, it's not. Bleeding may occur due to platelet reduction. So how we diagnose? Well, the low serum or the red blood cells folate, decrease hemoglobin and hematocrit, but increase in hemocysteine with normal MMA, differentiated from B12 deficiency. Must interpret with clinical history due to test variability. So then medical management, it's oral folic acid supplementation, dietary changes. So make sure you take dietary intake or folate-rich foods like leafy greens, legumes, fortified cereals. Supplementation during pregnancy, alcoholism, GI resection, or interfering medication. Complication untreated. This anemia affects function and cognition. Neurologic symptoms, confusion, are reversible. During pregnancy, deficiency may cause fetal neural tube defects. Neural tube defects. What else? What a nurse will do will assess for fatigue, nutritional history, alcohol use. So assess for anemia symptoms and neuro changes, confusion. Always monitor for labs, hemoglobin, serum, and red blood cells, folate, and homocysteine. Evaluate dietary intake and history of GI disorder or alcohol. So nurse will intervene, ensure folate-rich diet, administer supplements. So differentiate from B12 anemia to avoid masking neuro symptoms. Assess meds that intervene with absorption, and that might be like phenytoin and methotrexate. So you encourage for supplements of folic acid, dietary like green leafy vegetables, and always reassess the CBC. To evaluate outcome, so resolution shows by increase of hemoglobin and folate, improve fatigue and short of breath. Parental folate prevents neural tube defects. Persistent neuro symptoms warrant B12 testing. Sickle cell disease or sickle cell anemia, it's inherited hemoglobin disorder, hemoglobin S, common in individuals of African, Mediterranean, Middle Eastern, and Indian descent. Requires inheritance from both parents. Complications include stroke, pain, crisis, infection, and organ damage. So it's inherit hemoglobin S. We have hemoglobin S causes the red blood cells to sickle under low oxygen, rigidity, vaso-occlusion, hemolysis. Sickle cell live about 15 to 20 days versus 120 days by normal. Crisis type, it's vaso-occlusive, aplastic, sequestration, and hemolytic. So abnormal hemoglobin S causes the red blood cells to sickle under stress and leads into the vaso-occlusion, ischemia, and hemolysis. So clinical manifestation is severe pain, fatigue, anemia, jaundice, swelling in hands and feet, infection, delay growth. So keep in mind fatigue, pallor, it's all anemia, short of breath, but they have extra this pain in the joints, chest, and abdomen, swallowing, jaundice, hand-foot syndrome, infection, also it's delayed puberty, priapism, and impaired healing. So how we diagnose hemoglobin electrophoresis confirms the hemoglobin S, CBC, low hemoglobin, and increase in reticulocytes, increase in bilirubin. Newborn screening is standard in many countries. So for we have the hydroxyurea to increase fetal hemoglobin, pain control with opioids, hydration, transfusion, iron chelation for overload, bone marrow transplant, it's curative but risky. Oxygen only for hypoxia. So keep in mind hydration, oxygen, opioids, hydroxyurea, folic acid, blood transfusion, blood marrow, bone marrow transplant for curative. Complication might be acute chest syndrome, stroke, infection, developmental delays, pregnancy complication, splenic sequestration, iron overload from transfusion. Nurse will monitor for vital signs, pain, pallor, jaundice, infection signs, assess psychosocial impact, hands, foot deformities, delayed growth, hemoglobin, bilirubin, and nutrition status. So, acute chest syndrome is like stroke, organ failure, mistreated, that shiggling. It's consistent, actually episodic, and triggered. triggered. So you give oxygen if it's hypoxic, IV fluids, opioids for pain, blood transfusion, antipyretics, psychosocial support, infection control. So always you assess for pain, oxygen saturation, hydration, signs of infection or stroke. And outcome, fewer crises, stable hemoglobin, improved quality of life, knowledge of disease management, genetic counseling recommended. So pain control, fluids, oxygen, administer hydroxyurea, educate on infection prevention, and whatever triggers. Aplastic anemia, it's a rare condition affecting 2 to 4 per million annually. Peaks in childhood, young adults 20 to 25, and adults above 60. Causes include genetic mutation, toxin, infection, or idiopathic. So aplastic anemia, it's rare, can be congenital or acquired, like radiation drug, autoimmune. Pathophysiology, it's a bone marrow failure, leads to pancytopenia. So it's a reduce in red blood cells, reduce in white blood cells, and platelets. So keep in mind, bone marrow failure leads to pancytopenia. So this is triggered by immune-mediated stem cell suppression and cytokine release. Medical manifestation is fatigue, short of breath again, tachycardia, pallor, dizziness, bleeding gums, nose, bruising, infection, and prolonged recovery from illnesses. So fatigue, bleeding, infection, pallor, tachycardia, this is like the symptoms. Diagnostic, how we diagnose again, CBC shows pancytopenia. Bone marrow biopsy reveals hypocellular marrow with fat cells. Coagulation test, iron panel, and hemoglobin electrophoresis aid in diagnostics. So the bone marrow biopsy. Then we have Medical management in mild cases, transfusion, growth factors, apoetin, fligaries. In severe cases, immunosuppressant or bone marrow transplant. Minimize transfusion pre-transplant to avoid sensation. Then complication, it's a hemorrhage, infection, tissue hypoxia, graft versus host disease after transplant. Mortality rate, it's less than 70% without, it's more than 70% without treatment. So keep in mind hemorrhage, sepsis. The nursing management, monitor for infection, bleeding, fatigue, neutropenic precautions. So you will assess for to monitor the vital signs, bleeding signs, fatigue, labs, oxygen levels, infection. Assess for dizziness, headaches, pallor, bone marrow, confirms the diagnostics. And you administer oxygen, transfusion, protect from trauma, bleeding precaution, monitor nutrition, limit exposure to infection. The outcomes: stabilized blood counts, improved oxygenation, no bleeding or infection, improved in energy. Educate on infection signs, activity limits, and emergency symptoms. So keep in mind that the reverse isolation, educate on hand hygiene, avoid invasive procedures. So the glucose 6-phosphate, it's X-linked recessive, most common in African, Asian, Mediterranean population. So keep in mind the X-linked recessive enzyme disorder. So it's most commonly triggered by fava beans and sulfa drugs, NSAIDs, infection or stress. So this is different than other anemias, fava beans and sulfa drugs. So please keep in mind their keywords. The pathophysiology: lack of G6PD impairs the red blood cells' ability to handle oxidative stress to hemolysis. The red blood cells break down, releases bilirubin, and reduce lifespan. The hen's body and the bites cells seen on smear. So keep in mind deficiency of enzyme, the G6PD, it's the red blood cells vulnerable to oxidative stress. So leads to hemolysis after exposure to triggers. Clinical manifestation, it's jaundice, dark urine, fatigue. So dark urine, it's another keyword for this. Fava bean, sulfa drugs, jaundice, dark urine. Keep in mind on these keywords. Fatigue, back pain after fava beans, sulfa drugs, or infection. How we diagnose the G6 Again, the CBC, reticulocyte count, bilirubin, and one more thing, you will look for splenomegaly, so the enlarged spleen, often asymptomatic until triggered by those like favabine, sulfa drugs. And in CBC, you'll see again low hematocrit and hemoglobin, increase in reticulocytes, hence body on smear DNA sequencing of G6PD gene confirms diagnostics. Elevated liver enzyme and indirect bilirubin. So avoid triggers like meds and food, transfusion if severe anemia, folic acid for erythropoiesis. So this is a keyword of how the red blood cells is made. The splenectomy, the large spleen for severe splenic sequestration. Keep in mind hydration, it's a key. Avoid triggers, support care during hemolytic episode. So that can be a treatment complication. Hemolytic crisis, kidney injury. Severe anemia, renal injury, neonatal jaundice, and another fancy word, kernicterus in infants. Nursing management assess vital signs like all of it, fatigue, pallor, jaundice, and urine color. Monitor for CBC, smear, bilirubin, reticulocytes count, assess for short of breath, and hepatosplenomegaly, so the liver and the spleen enlargement. You will need to oxygen to administer if hypoxic for everybody. Administer folic acid, monitor for anemia signs, bleeding precaution, prevent exposure to triggers. So keep in mind also you need to assess for medical history, dietary intake, and hemolysis signs. And the outcome, it's patient teaching on triggers, hydration, monitor labs during episode, avoidance as much possible on triggers to reduce the episodes, improve perfusion, reduce fatigue and jaundice, patient understand the medication and diet restriction, and to have a make sure that the patient will know and write down when and tell to providers that they have this in case they change providers or change cities, change counties, change countries. It's very important. Polycythemia vera, so it's a anemia, but with increase. Poly means a lot. So it's a rare, 5 in 1 million annually, more common in men over 60, caused by GAK2 gene mutations. Secondary polycythemia may result from hypoxia or tumors. Not inherit, but can run in families. So it's chronic myeloproliferative disorders, typically diagnosed in adults over 60. So what it is, bone marrow overproduces the red blood cells. That's why it's poly. So it's overproduction of red blood cells. The white blood cells and platelets. So it's over. Poly means many and much, which increase blood viscosity and volume. So these excess of red blood cells increase this blood viscosity, impairing circulation. So this type of anemia involves panmyelosis, which is increase in red blood cells, white blood cells, platelets. Secondary polycythemia is due to excess of erythroprotein from hypoxia or tumors. Clinical manifestation: it's short of breath, of course, especially supine, dizziness, headache, fatigue, blurred vision. So has blurred vision. Pruritus after bath. So this is another key word. Pruritus after bath. Flushed face, splenomegaly, weight loss, thrombosis, or bleeding. Having headache, dizzy, keep in mind after hot shower, these pruritus. Then how we diagnose? Of course, blood. The CBC shows increase in hemoglobin, increase in hematocrit, increase in red blood cells, GAK2 mutation, decrease in erythropoietin, and increase in secondary. Bone marrow biopsy shows the panmyelosis. So keep in mind the bone marrow biopsy. Therapeutic phlebotomy, target hematocrit less than 45%, hydroxyurea or interferon for marrow suppression, low dose aspirin or anagrelide for clot prevention, treat secondary causes, avoid heat or cold. So keep in mind low dose aspirin. And then complication: thrombosis, hemorrhage, leukemia, gout, kidney stones, heart failure from hyperviscosity. So the thrombosis, stroke, hemorrhage, know that the pruritus is histamine mediated, not from dryness. What a nurse will do: monitor for pruritus, flushing, vision changes, thrombosis symptoms, and organ congestion. Assess for elevate uric acid, splenomegaly, headache, and visual disturbance. Encourage hydration, elevate legs, avoid tight clothing, monitor CBC and uric acid, bleeding precaution, rest periods, moderate exercise, DVT prophylaxis. The evaluate outcome, of course, we like to educate on hydration, avoid tight clothing, encourage mobility, monitor for labs, hematocrit maintained below threshold, improve perfusion, prevention of clothing and bleeds, and improve quality of life. Lifelong monitoring and education is required, and not hot or super cold bath. Thalassemia is a genetic defect in hemoglobin B chain with severe microcytic anemia. So the beta thalassemia is an inherited blood disorder after affects your body's ability to make hemoglobin. This usually it's Mediterranean um, area. Labs very low in hemoglobin, low in MCV, target cells, increase in iron. Treatment, it's transfusion, iron chelation, is primarily a red blood cell disorder, and is characterized by the body's inability to produce enough functional hemoglobin, the protein in red blood cells responsible for carrying oxygen. This deficiency leads to anemia and various associated health problems, including potential damage to organs like the heart and liver due to iron overload from the frequent blood transfusion. And it's passed down to the parent genes. There are two main types of thalassemia, alpha and beta, but it's not much tested on this. It's just severe microtic anemia. Mostly they talk about beta, and it's inherited blood disorders and Mediterranean. That's it for this. The white blood cells disorders, leukemia, and it's divided in two main categories. This book doesn't specifically mention this, it's just one sentence they talk, and that's why I put these two here. But we'll go to leukemia mostly about this. Leukemias, there are quite a few of them. Malignant disorders of white blood cells. So genetic risk includes Philadelphia chromosome, higher risk in white males over 60. All in most common in IL, this one, most common in children. So this is cancer of white blood cells, and see this one, CLL. It's most common in this is common in adults, and this and this and this is in children. And pathophysiology, it's that the mutation in lymphoid or myeloid stem cell leads to overproduction of immature white blood cells, the blasts. Those infiltrate bone marrow, reducing red blood cells and platelet production. So the proliferation of abnormal white blood cells grounds then bone marrow, which leads to decreased red blood cells, platelets, and normal white blood cells. Clinical manifestation is fatigue, bruising, infection, fever, bone pain, swollen lymph nodes. Again, we see also in this disorder splenomegaly, fatigue, pallor, bruising, petechiae infection, but the swollen lymph nodes, bone pain, weight loss, this is more keywords for this disorder. So how we diagnosed? CBC shows low leukocytosis, anemia, thrombocytopenia, flow cytometry, and bone marrow biopsy confirms. Genetic testing identifies chromosomal abnormalities. So, of course, keep in mind again CBC, peripheral smear, bone marrow biopsy also here, and cytogenic analysis. Treatment, chemotherapy, target therapy, bone marrow transplant. So, systemic chemotherapy in multiple phases, induction, consolidation, maintenance. The stem cell transplant or CAR therapy if refractory. Prophylactic antibiotics transfusion often needed. Complication is tumor lysis syndrome infection. Note that not all leukemias cause leukocytosis. Might be a normal or low. Infection from neutropenia, bleeding from thrombocytopenia, and organ damage, graft versus host disease, post-transplant. Infertility, neurocognitive effects, chronic medical condition. Assessment, nursing assessment, leukocytosis, neutropenia, anemia, thrombocytopenia, fatigue, pallor, dizziness, short of breath, bruising, petechiae, fever. So, monitor for infection, bleeding, fatigue, and mouth sores. Vital signs, CBC, monitor for bruising, petechiae, fatigue, short of breath, infection, chemo side effects, fertility risk. Evaluate outcome, administer chemo, start antibiotic if febrile with low ANC, neutropenic precaution, manage chemo side effects, transfuse blood products. So this neutropenic precaution, oral care, monitor labs, education on treatment phases. And no fresh fruit, crowd avoidance, and make sure you when every time the patient eats out needs a mask. And also sometimes people next to that come and visit needs mask. So neutropenia, we talked earlier. It's a condition characterized by abnormally low number of neutrophils, a type of white blood cells that plays a crucial role in fighting infection. So the causes of neutropenia can be caused by various infections, including chemotherapy and radiation therapy. Those treatments can damage bone marrow where neutrophils are produced. Certain infections such as oral or bacterial infection can consume neutrophils or suppress their production. Autoimmune disorders like conditions like rheumatoid arthritis and lupus can cause the immune system to attack neutrophils. Some medications such as metimazole and hydroxychloroquine can suppress neutrophil production. Bone marrow disorders, conditions like leukemia and myelodysplasia can affect the production of neutrophils. Genetic disorders, some rare genetic disorders can lead to neutropenia. What else we know about symptoms? That neutropenia might cause any symptoms in mild cases. However, severe cases it can lead to fever, fatigue, sore throat, mouth sores, skin infection, increased risk of serious infections such as sepsis. The diagnostic, it's diagnosed throughout the blood test, CBC, with differential. These tests measure the number of neutrophils in the blood. Treatment for neutropenia depends on the underlying cause. It might include antibiotics. If neutropenia is caused by an infection, chemotherapy. If neutropenia is a side effect of a cancer treatment, stem cell transplant in severe cases. A stem cell transplant might be necessary to replace damaged bone marrow. So the granulocytes colony stimulating factors, those are medications that stimulates the body to produce more neutrophils. To prevent, it is important to get vaccinated against the infection, avoid contact with people who are sick, and wash hands. Yes, hand hygiene. Okay. Now we are in bleeding disorders. I have these images. I hope you like. Inability to clot. It's the bleeding disorders. And now we go on these slides here. So what we know about thrombocytopenia? It's differentiating few like ITP, HIT, this is heparin, hemophilia, hereditary like hemophilia A, factor 8, this is a keyword, hemophilia B, Christmas disease, factor 9, these are the labs, so it's platelets, normal platelets, but increase in PDT, joint bleeds, decrease in platelets, so reduced platelets can be secondary to autoimmune disease, medication, malignancy, infection, common in women age of 15 to 40 after viral illness in children. Then it's caused by decreased production, increase in destruction, or increase in consumption of platelets. The autoantibodies often involved, especially in ITP. This one. Follow viral illness. So it's easy bruising, petechiae, gum bleeding, nosebleeds, GI bleeding, hematuria, possible brain hemorrhage in severe cases. So the CBC with platelet count will be below 150,000. Bone marrow biopsy, coagulation profile, PT and PTT, fibrin, split products for DIC, and stop heparin in HIT. Stop heparin because this is heparin induced. Hemorrhage, it's the biggest risk. Spontaneous bleeding when platelets, it's around 20,000. With DC, the DIC can cause multi-organ failure, and with HIT can lead to thrombosis. So always look for bruising, bleeding gums, petechiae, signs of internal bleeding. Evaluate platelet counts, PT, PTT, fibrinogen if DIC is suspected. So again, risk for bleeding that the nurse will have to assess and always to intervene. Risk for bleeding, ineffective regimen management, fear of hemorrhage, and hemorrhage due to low platelets, tarry stools, hematuria, blood in urine. Monitor for ecchymosis, trauma, rectal and vaginal. We have to monitor platelets count, check for petechiae and mucosal bleeding, watch for tarry stools or hematuria, monitor for ecchymosis and lab values. And you need a soft blood pressure cuff to don't cause the bruising, and soft toothbrush, electrical razor, not that one, electrical razor for shaving. Von Willebrand disease. What it is the most common inherited bleeding disorder. Affects the blood ability to clot properly. So it affects that. The factor, it's a protein that helps the blood platelets stick together and attach to the blood vessel wall at the site of an injury, initiating the clotting process. In this process is disrupted, causing impaired blood clotting. So the labs, it's decrease and increase in APT. The book, it shows just very brief. It's not just think about this fancy name. It's inherited bleeding disorder, and it's because it's bleeding, and you need to know it's the same medical manifestation and nursing intervention from all the above I said for bleeding disorders. We're in the last category, lymph disorders, malignant and multiple myelomas. We're gonna go with Hodgkin lymphoma and non-Hodgkin lymphoma. For Hodgkin, here you see between them what is the compare and contrast. So for the Hodgkin lymphoma account for about 14% of lymphomas, most common in person of European descent, B mondal age, disruption on young adults after age of 55, higher survival rate, versus non-Hodgkin lymphoma accounts for approximately 86% of lymphomas, more common in males and persons of European descent. Incidence peaks in pre-adolescence and late in adulthood. So Hodgkin lymphoma evolves from a single progenitor cell characterized by presence of red Sternberg cell spreads in an ordinary fashion throughout lymph nodes, versus non-Hodgkin lymphoma, which evolves from B or T lymphocytes, includes many subtypes, often disseminates on non-contiguously to extranodal sites. On Hodgkin lymphoma, the Epstein-Barr virus infection, family history, first-degree relatives, versus on non-Hodgkin, it's autoimmune disease, HIV, Epstein-Barr virus, pesticides, immunosuppressive therapy, certain bacteria like H. pylori. Hodgkin lymphoma, a clinical manifestation, painless lymph node swelling, low-grade fever, night sweats, weight loss, fatigue, pruritus, persistent cough if mediastinal mass presents. In non-Hodgkin, it's similar clinical manifestation like Hodgkin, painless lymph node swelling, systemic B symptoms like fever, night sweats, weight loss, fatigue. To do the lab to diagnose CBC, LDH, uric acid, viral test, imaging, X-ray, CT, PT, PET scan, lymph nodes biopsy, possible bone marrow biopsy or lumbar puncture. For non-Hodgkin lymphoma, it's same as Hodgkin's, lab test, imaging, lymph nodes biopsy, bone marrow biopsy if needed. How we treat chemotherapy, radiation, immunotherapy, transplant if relapse occurs. Indolent causes may follow a watchful waiting approach. Chemotherapy also for the Hodgkin, non-Hodgkin, radiation also, immunotherapy, also stem cell transplant for relapse or refractory causes. Complications, superior vena cava syndrome. This is for Hodgkin lymphoma, spinal cord compression, hypercapnia, calcemia, myelodysplasia, infection, anemia, thrombocytopenia. For non-Hodgkin, some complications as same as Hodgkin, including severe hepatic and renal dysfunction, thrombotic events, and potential for splenectomy. Nursing intervention, low-grade fever, fatigue, we need to evaluate, assess for low fever, fatigue, edema, enlarged nodes, CBC changes, pain, pruritus, neurological deficits. For non-Hodgkin, we monitor for same symptoms, assess for tumor burden or systemic effects, including bone marrow suppression. We need to administer chemo and also to evaluate for side effects. We have IV fluids, blood products, monitor for CBC, manage symptoms, itching, nausea, pain, no bleeding, infection, symptoms relief, uninterrupted therapy. For non-Hodgkin, it's same like Hodgkin, it's assess and give chemotherapy, fluid, symptoms, management, transfusion, extra attention to organ function. So you see, it's superior vena cava, I highlighted. It's a key word that you need to keep this in mind. Spinal cord compression, right? The B symptoms, it's Hodgkin's, it's a red flag. Multiple myeloma, it's a hematological malignancy of B-cell origin, most common in older adults. African descent and males. Risk factors include exposure to radiation, chemicals, and certain occupation. Pathophysiology is proliferation of monoclonal plasma cell producing IgG or IgA. Leads to bone lesion, hypercalcemia, and renal damage due to Benz-Jones proteins. Clinical manifestation, it's bone pain, especially back, hip, fatigue, pallor, weakness, infection, hypercalcemia, renal stones, anemia, and paresthesia. The clinical, the diagnostic, it's CRAB criteria, calcium, renal insufficiency, A for anemia, and B for bone disease. Monoclonal proteins in serum, urine, Benz-Jones proteins, bone marrow biopsy imaging. And treatment, we have chemotherapy, the thalidomide, lenalidomide, bortezomib, corticosteroids, bisphosphonates, autologous stem cell transplant, radiation therapy, thrombus prophylaxis. Complication, a bone fracture due to lytic bone lesion and weakened bones. The hypercalcemia from bone breakdown leads to confusion, weakness, dehydration, and kidney problems. Renal failure caused by Jones protein accumulation, and hypercalcemia damaging the kidney. Nursing management, anemia, infection, bone fracture, spinal cord compression, renal failure, hypercalcemia, neurological deficits, and complications from treatment. Monitor vitals, manage anemia and pain, administer chemo, and the bisphosphonates, assess renal function and calcium, encourage fluids and mobility, position and comfort. Nursing also needs to educate on symptoms of anemia and fractures, nerve issue, importance of hydration, recognizing infection, and need for ongoing follow-up and emotional support. So keep in mind back pain, proteinuria plus hypercalcemia, it's myeloma. And that's it for this. This is kind of a summary, the learning outcomes, what we learn. So the book offers like content in this chapter. It's designed to assess in. So one, describing the epidemiology of disorders of hematological system. So hematological disorder affects millions globally and vary by type, age, and geography. Iron deficiency anemia is the most common worldwide, especially in women and childbearing age. Sickle cell disease predominantly affects individuals of African, Mediterranean, or Middle Eastern descent. Leukemia is the most common childhood cancer. Malignant lymphomas and multiple myeloma are more prevalent in older adults. So, example, a teenage male with Mediterranean background presenting with fatigue and pallor may be at high risk for thalassemia. So, quiz question. Which hematological disorder has the highest globally prevalence? Answer is iron deficiency anemia. On the second, 2, correlating clinical manifestation of two pathophysiological process of non-malignant and malignant hematological disorders. So if we go one by one, quick, iron deficiency anemia. So it's microcytic, hypochronic anemia, fatigue, brittle nails, pica. And you need to give vitamin C. Oh, this is clinical manifestation. Not jumping. No, Mia, no jumping to treatment because it's clinical manifestation. Vitamin B12, it's microcytic anemia, glossitis, paresthesia, memory changes. Folate deficiency, similar to B12, but without neurologic symptoms. Sickle cell anemia, abnormal hemoglobin cause sickling, is that S, pain, crisis, infection, organ damage. Aplastic anemia, it's pancytopenia due to marrow failure, fatigue, bleeding, infection. G6PD is the glucose 6 deficiency. It's the hemolysis after exposure to triggers like fava bean sulfa drugs. Polycythemia vera, increase in red blood cells. Hyperviscosity, headache, thrombus, and petechiae after shower, and flashy face. Idiopathic thrombocytopenia purpura, ITP, autoimmune platelet destruction, petechiae bleeding. Leukemia, malignant white blood cells, anemia, infection, bruising, lymphoadenopathy. Malignant lymphoma, solid tumors in lymph tissue, painless, lymphadenopathy, B symptoms. B symptoms. Multiple myeloma, plasma cell malignancy, bone pain, hypercalcemia, kidney failure. So example, a patient with pallor, paresthesia, and macrocytosis likely has B12 deficiency. So quiz question, which disorder is associated with neurological symptoms due to demyelination? So the answer is Pernicious anemia. So 3, describing in the diagnostic results used in common disorders of hematological system. So very quick, CBC is most common. The red blood cells, white blood cells, platelets, MCV, MCHD, reticulocytes count, bone marrow activity, peripheral smear, cell morphology, serum ferritin, iron, right? Iron studies, vitamin B12 for folate levels, hemoglobin, electrophoresis for sickle cell and thalassemia. Bone marrow biopsy for leukemia and aplastic anemia. Coagulation studies, PT, PTT, INR, and IPT. Serum protein electrophoresis for multiple myeloma. Example, elevate MCV with low B12. So it's macrotic anemia. So quiz question, which test best confers multiple myeloma? Answer is serum protein electrophoresis. 4. Discussing the interpersonal management of identified hematological disorders. Here, hematological disorders require a team approach, like physicians to diagnose or treatments, nurses to monitor labs, administer meds, provide education, dietitians manage nutrition like iron, B12, folate, pharmacies monitor for drug interaction, social worker assist with access to care. Example, a patient with anemia may need iron supplements, dietary counseling, and follow-up labs. Quiz question, which team member ensure dietary intake meets folate needs? So, registered dietitian. 5. Developing a comprehensive nursing care plan. So nursing care includes like assess for fatigue, pallor, bleeding, infection, monitor for CBC, virals, bleeding, bruising, administer medication, apoethine, iron, steroids, chemo, educate on disease process, meds and signs of complication, encourage rest, proper nutrition, infection precaution, Example, aplastic anemia patient needs eutropenic precaution. Quiz question. What is the nursing priority for a patient with thrombocytopenia? So the answer is monitor for bleeding. 6. Designing plans for care with designing a care plan that includes pharmacological, dietary, and lifestyle factors. So pharmacological, iron B12, injection, erythropoietin, hydroxyurea for sickle cell, corticosteroids, chemotherapy. Diet, iron-rich food, spinach, red meat, folate, leafy greens, B12, animal products. Lifestyle, avoid infection, maintain hydration, prevent injury, avoid triggers in glucose 6. Example, sickle cell patient benefit from hydration and pain management. Quiz question, what food should be increased in iron deficiency anemia? So red meat, dark leafy greens, and also they can drink orange juice for increase of absorption. 7, the last one, coordinating interprofessional care for hematological disorders. Coordination ensure safe and timely care, communicate the labs and status changes to physician, schedule follow-ups, transfusion, treatment, collaborate with the case managers and social workers, teach patient when to report complication, bleeding, fever. Example, a nurse calls provider to report the critically low hemoglobin needing transfusion. So quick quiz question, who is responsible for coordinating lab review, transfusion orders, and patient teaching? The answer is the nurse. And that's it. It's been a long chapter and very detailed. I hope this outline make more sense to learn your blood disorders, disorders. Okay, I hope you enjoy. Give me a comment and tell me if it was helpful. So see you next time. Thank you again for your time and trust. I'm Lymphoma, and from my heart to yours. Until next time, stay zen, stay grounded. Namaste. Bye for now.